Hi, my name is Ben Sirica, and I'm going to cover post-cardiac arrest care. A little bit more about me. I am at Brigham and Women's Hospital in Boston. I am an attending cardiologist in the cardiac intensive care unit and an associate professor of medicine at Harvard Medical School. These are my disclosures. So let me start with a case. This is a 58-year-old man who at 11 a.m. complained of some arm and shoulder pain and subsequently collapsed at 12:23. He was fortunate that his roommate initiated bystander CPR and 911 was activated. When EMS arrived, they identified him in ventricular fibrillation, and he was intubated and defibrillated multiple times before return of spontaneous circulation. And when he had his first ECG done, it was notable for an ST elevation here, where you can see fairly impressive ST elevations inferiorly and in the apical region. On exam in the emergency room on his way to the cath lab, he was unresponsive to voice or sternal rub. His pupils were fixed at 8 millimeters. He didn't have any oculocephalic reflexes. And his gaze incontinent was midline and his face symmetric, but he had no spontaneous lip movements or responses to painful stimuli, which, if one were to calculate the Glasgow Coma Scale, would give him a 3 out of 15, so quite low. He was taken emergent to the cath lab, where a left circumflex artery was found to be 100% occluded and was successfully reperfused with the deployment of a stent and good post dilation flow into the coronary arteries. And his time from cath lab arrival to reperfusion was just 23 minutes. His door to reperfusion times was 51 minutes, which was impressive and a goal, because our goal, we know that mortality will increase in acute STEMI by 7.5% for each 30-minute delay in time to reperfusion. So we feel good about his heart. And now we have to deal with the rest of his care after resuscitation. And as we think about post-resuscitative care, it's important to remember what are often referred to as the chains of survival. And these include everything from the beginning of a hospital cardiac arrest, where there's activation of emergency response, CPR, defibrillation, advanced resuscitation, or inpatient cardiac arrest, where there's, again, early recognition and prevention, calling the code team, CPR, defibrillation. And both of them then talk about the importance of post-cardiac arrest care as one of the key links, combined with recovery for those patients who make it out of the hospital, which is a more recent link that is important as patients are surviving these catastrophic events. One of the most concerning and frustrating parts of post-cardiac arrest care is that there is often significant neurologic injury. And some of the key tenets in post-cardiac arrest care are to first determine and treat the causes of arrest, minimize the brain injury, manage the cardiovascular dysfunction, and then look at all the problems that may arise from global ischemia and reperfusion around the body, of which the brain is the most concerning. And this flow diagram from one of the AHA ACLS guidelines is a nice way of looking at the high-level recommendations for somebody who has spontaneous or return of spontaneous circulation. At the top here, first is managing the airway, setting the appropriate respiratory parameters, then managing blood pressure. We'll talk about all of these in more detail. Then getting that ECG. And that's the first branch point. And if somebody does have ST elevation, going to a cath lab. The next question really is, are they following commands? And if they do not, then they're considered comatose, where we have to think more about what are the best and optimal ways to maximize their ability for neurologic recovery. What are the appropriate imaging? And a CT scan is usually done immediately. And then what are the longer term monitoring, meaning days after this arrest, to assess for neuroprognostication. And that's what we'll spend much of our time talking about in this talk. First, just a quick mention that to remind everybody that in patients with ST elevation MI and out of hospital cardiac arrest, there is a class 1 level of recommendation that coronary angiography should be performed in all patients with ST elevation on their ECG, regardless of their neurologic status. And that's the example of the case that I sent there. The fact that a patient is comatose and not responding, if they come in after a cardiac arrest and have ST elevations on their ECG, they should go to the cath lab with the eye of immediate reperfusion. Now, there's a lot of questions about the role for routine catheterization in out-of-hospital cardiac arrest, meaning in the patients with non-ST elevation ACS, or in cases where it may not be felt to be from an acute coronary syndrome. And there have been several studies that have done this, and they've all been pretty consistent in that they have not shown any benefit in terms of overall survival with immediate and routine coronary angiography compared to a strategy of delayed coronary angiography. And we in Brigham and Women's Hospital tend to defer coronary angiography in patients without ST elevations until we do understand better what their neurologic status is after a cardiac arrest. Now, the guidelines are continuing to evolve, and we'll talk about this, but these are the most recent 2020 AHA guidelines for targeted temperature management. And at this time, the data recommended that all patients who are comatose after return of spontaneous circulation should get some type of targeted temperature management. They also recommend that for inpatient or in-hospital cardiac arrest from both shockable and non-shockable rhythms. So the recommendation from 2020 is TTM, targeted temperature management, in all patients. And at that time in 2020, the recommendations were for a temperature between 32 to 36 degrees centigrade of temperature management for at least 24 hours after achieving target temperature. Now, why were these recommendations there? We'll talk about that and talk about, again, how the field has evolved over the last decade. First, there is a lot of basic physiologic evidence that cooling can very much change the physiology of the brain, especially after it has undergone an anoxic injury. Cooling will decrease cerebral metabolic oxygen consumption. It decreases cerebral blood volume through vasoconstriction, which can decrease intracranial pressure. Cooling has anticonvulsant properties, and in animal models, it can abort activated programmed cell death or apoptosis, and it decreases the inflammatory response after a cardiac arrest. Remember, there are two major insults to the brain with a cardiac arrest. The first is the initial anoxic injury, when somebody does not have blood flowing through their body. That is best managed with CPR and early ACLS. And then the second injury is a post-reperfusion injury, which is associated with the edema, the apoptosis, and release of excitatory toxins like calcium and glutamate. And so what we're talking about, the post-cardiac arrest, is obviously the second phase of that injury. Now, in 2002, two studies came out comparing hypothermia, it was called then, and normothermia. And hypothermia was 32 to 33 degrees centigrade. And these were relatively small studies, one from Europe, one from Australia, and both demonstrated improved neurologic outcomes and clinical outcomes with cooling compared to doing nothing. And this was really the beginning of the induced hypothermia targeted temperature management field. Now, a decade later, a very well done study called the TTM, or now called the TTM1 study, tested 33 versus 36 degrees after cardiac arrest. And this was in over 900 patients who had all types of cardiac arrest, an outpatient from out of hospital cardiac arrest, and found no difference in terms of outcome of survival between the two temperatures. And even in subgroups, whether it was shockable, non-shockable, the time to return of spontaneous circulation, bystander versus no bystander CPR, all of the subgroups were consistent that the two temperatures were similar. Now, it's important to note, and this was a discussion point at the time, that 36 degrees is still not doing nothing and requires active temperature management. And here on the left, you can see the temperature curves from the TTM1 trial, where 33 degrees versus 36 degrees, that is compared to a normal temperature of 37.8, which is what was done in the original trials, the HACA trial, for example, from 2002, where patients were not given any temperature control and were allowed to sort of auto-regulate after their arrest in the normothermia group. Now, that was the study of the TTM1 trial. There have been other important studies now. The next one is now the follow-up of the TTM trial, which is the TTM2 study, which came out just about a year ago. And it was looking at hypothermia versus normothermia out of hospital cardiac arrest patients, 1,861 adults who were comatose. This is the largest cardiac arrest study I think ever performed. Very well done. Looked at two strategies, again, 33 degrees centigrade, so the cooler temperature, versus normothermia. And in this case, normothermia was keeping the temperature less than 37.8. So it wasn't doing nothing. It was enforcing normothermia, keeping people below 37.8. Primary outcome was death from all causes. And this was done in multiple countries, multiple institutions, and had very good study metrics in terms of loss to follow-up and analysis. And the study, like the TTM1 trial, showed no difference in overall survival up to almost 6 months between the group that was cooled to 33 degrees versus the group that was normothermia, or less than 38 degrees centigrade. And that was consistent, again, throughout the different subgroups, whether it was sex, age, time to ROSC, initial rhythm, or whether they were had presence of cardiogenic shock or any shock on admission, there was no difference. And if you look at adverse outcomes, the only difference really between the two groups was that there was more arrhythmias in the hypothermia group, and these tended to be almost always bradycardic events that may have resulted in some need for inotropes. Now, again, comparing normothermia in TTM2 versus doing nothing, we can look at the HACA trial on the left again, where nothing is that top line, versus the TTM2 trial, where they kept people at 37 degrees and actively prevented fevers as well. And in the TTM2 trial, almost half of the patients in this normothermia group still required a cooling device to be used to enforce normothermia. Cooling devices tended to be mostly blankets and the type of surface cooling devices, but almost half of patients did require active temperature management to maintain normothermia. So what did this lead to? This led to some new recommendations, and these are from the International Liaison Committee on Resuscitation, or ILCOR, which they released these in 2022, and their recommendations based on the TTM2 trial and other data is that actively preventing fever by targeting a temperature of less than 37.5 for patients who remain comatose after cardiac arrest is indicated. Patients who are mildly hypothermic after return of spontaneous circulation should not be actively warmed to achieve normothermia. This is quite common, that somebody after a cardiac arrest and return of spontaneous circulation may come to the intensive care unit and their first temperature is 36 degrees or even 35 degrees. And the recommendations are not to actively rewarm them. I typically just keep them at that temperature or put on the Arctic sun or one of the surface temperature controllers to ensure that they don't get too high. They recommend, third point, they recommend against the routine use of pre-hospital cooling with IV fluid. This has been studied and did not demonstrate any benefit. And they suggest surface or endovascular temperature control techniques when needed to control temperature. And they suggest the active prevention of fever for at least 72 hours in post-cardiac arrest patients who remain comatose. And there is the feeling now that it is the fevers, if anything, that may be the most detrimental to the brain in the post-cardiac arrest period. And therefore, the best plan is to prevent the fevers, meaning having the temperature control tools in place to prevent the fever in the first place, rather than reacting to the fever and then doing it after they spike. Now, our Mass General Brigham policy was updated this year to reflect this. And what we say is that, again, the goal of is to initiate temperature control, and that's what we're calling TTM now, temperature control as soon as possible after successful resuscitation. And this should happen at first medical contact, and patients should be determined what their temperature control strategy should be as early as possible. In the case of STEMI patients, there shouldn't be any delay in transfer the patients to the cath lab, but the temperature monitoring should begin immediately after resuscitation. We recommend bladder temperature as the preferred method, and that the temperature control can be implemented anywhere. We are very broad in our patient selection for temperature control, meaning that any patient who has return of spontaneous circulation and is comatose after ROSC is eligible. We do not calculate the Glasgow Coma Scale. We keep it simple and just, is there lack of meaningful response to verbal command? And if the answer is no, then they are comatose by our definition. What do we recommend? We recommend that the default temperature control is to avoid fever and maintain a temperature of less than 37.5 or 99.5 for at least 72 hours. We recommend this by using active temperature management systems. We allow passive rewarming up to 37 degrees, but not active rewarming. We do give the option for targeted mild hypothermia, 33 to 36 degrees, if there is any clinical indication for that or any clinical reason for that. It's unclear exactly who that should be, but there are ongoing clinical trials that are still testing different temperature managements that we're involved in. And so we want to give the ability for clinicians still to be able to use this if they feel there's an indication, because we don't think that there is any overwhelming safety concerns with this strategy that would prevent it. Our overall duration of temperature control should be at least 72 hours after ROSC. And if a patient is undergoing mild hypothermia, then that should be done for 24 hours, followed by normothermia for 48 hours. This is sort of where we are in 2023, and this is a nice figure in that it's important to remember that enforced normothermia, which I think is what we should be doing, is not the same as no temperature management. And we have moved, I think, for this 72 hours of fever control with enforced normothermia, then looking at a time of structured neuroprognostication, which we'll talk about just in a minute. Now, the American Heart Association guidelines have not been updated. We expect that actually at the end of 2023. And so keep an eye out for the most updated American Heart Association resuscitation guidelines. How long should this temperature management be done? Again, this is an area of continued evaluation. This study is looked at active device-based prevention, fever prevention for 36 to 72 hours. This came out after the TTM2 trial and found no difference in overall survival between 36 and 72 hours of enforced temperature control. And so it may be okay to be shorter than 72 hours. The guidelines aren't there yet, but there is now this study to be able to provide a little bit more insight. This is the study I mentioned, the IceCap study, which is being performed across multiple sites. It's looking at patients who are survivors of cardiac arrest, regardless of the rhythm. And it's looking at a variety of different durations of cooling. So it's going a little bit in the other direction, like, is it better to cool somebody for up to 72 hours and then rewarm them versus cooling them for just 6 hours? This will still be a couple of years to find the results, but I think with this study, it will be testing now the other end of longer cooling to make sure that, part of the reason we're seeing no difference between 24 hours of different temperature controls is that we aren't doing it long enough. Now, how do we control temperature in 2023? And, ice bags, standard cooling blankets, and then specialized cooling devices are the optimal ways of doing this. If somebody is febrile, cooling them as quickly as possible, whether it's ice bags or standard cooling blankets, is really important. If you are enforcing normothermia and really need and want to keep a close eye on the temperature, which I think is important, then specialized surface cooling devices, I think, are the optimal way. Intravascular cooling catheters can be quite effective, but they obviously introduce another risk of infection and procedure-related complications. Now, what happens when somebody does cool somebody to 36 and certainly to 33? You can have a lot of effects on physiology. You decrease metabolic demands, you decrease CO2 production and O2 consumption. Bradycardia is the predominant arrhythmia of cooling, which includes PR prolongation, QRS widening, and QT prolongation, though there's no evidence that it's actually arrhythmogenic. If you're measuring central or mixed venous saturations, cooling will increase those. It decreases gut absorption and motility and causes a pretty impressive insulin resistance. Now, if you are cooling somebody to 36 degrees or below, they really do need to be sedated and pain controlled, because the goal sedation level for these patients is pretty deep. It's a RASS of -4, -5. Nobody wants to be 33 or 36 degrees and be awake. And regardless of RASS level, meaning are they comatose or not, sedatives should be initiated if you're aiming for mild hypothermia. Propofol is the preferred agent because it's rapid on, rapid off, and a low-dose analgesic agent like fentanyl is preferred for pain control. Now, if somebody is just being enforced normothermia at 37 degrees, then they should just get a sedation goal of a RASS 0 to -1, typical of most intubated patients with constant reassessments. Now, neuromuscular blockade is not recommended for patients who you want to get hypothermia. However, it can be, especially a bolus of a neuromuscular blockade, can be very effective for achieving rapid cooling just because there is often some shivering or subclinical shivering that may prevent somebody from being cooled quickly. Now, here is a little bit of a summary of what are the hemodynamic parameters we're looking for in patients who have had cardiac arrest. And you can see this highlights a couple important aspects. The first is we do almost always need to give volume. Patients after a cardiac arrest do tend to have a vasoplegia, as well as potential cardiac dysfunction, but certainly a vasoplegia, and often are relatively intravascularly underfilled. A MAP goal we'll talk about, but standard MAP goal of 65 is appropriate with good urine output. And in terms of the respiratory targets, PaO2, SaO2, PaCO2, we are aiming for the standard parameters. There is no benefit of either underventilating or overventilating, or certainly no benefit of supra-oxygenating patients. And typical lung protective ventilation strategy is indicated. Now, infections are quite common after cardiac arrest, and I don't think it's just because a lot of these patients are cooled. I think it's common for a lot of reasons. First, many patients aspirate in the time of the arrest or when they're being intubated, often in the field. Secondly, they often have a lot of procedures, central lines, et cetera. So these patients are exquisitely sensitive to infections. The most common infections are bloodstream or catheter infections, followed by, pneumonia is the most common infection, followed by bloodstream or catheter. And then infections tend to be more hospital type acquired than community type acquired. So if somebody has a new infiltrate, increased sputum, white count, and worried about a pneumonia early on, it's best to treat them as a hospital acquired pneumonia rather than a community acquired pneumonia. The good news is the infection itself doesn't seem to be associated with much worse outcomes. And there's no benefit of prophylactic antibiotics in this patient. This has been studied. But as I said, early, broad, and aggressive antibiotics is important if there is signs of infection. Now, there have been a lot of studies now, some great studies that have come out over the past 2 or 3 years looking at how to optimize the blood pressures and oxygen, and these have all been published in the New England Journal. Here are the references. The biggest take home is there is no difference in outcomes according to the targeted PaO2, PCO2, or blood pressure. And so we really are doing nothing different in these patients than we would with our other intubated, critically ill patients in terms of their targeted hemodynamics and respiratory settings. Now, neuroprognostication is, I think, the most complex, frustrating, and challenging part of post-cardiac arrest care. And there's, again, been a lot of progress here, but I think it's still an area where it requires multidisciplinary interaction and very thoughtful conversations with families. And we use a combination of tools to predict neurologic outcomes: clinical exam, EEGs, and somatosensory evoked potentials, biomarkers, and then imaging, CT, MRI, and there are even some advanced MRI SPECT techniques. Now, the recommendations are that in patients who remain comatose after a cardiac arrest, that any prognostication involve multimodal approach and not be based on a single finding or test. It is important to wait after cardiac arrest. Patients take time to recover, and it is dangerous to use early indications to predict prognosis when those early indications may not be reliable. And therefore, a team of neurologists and neurocritical care doctors, as well as intensivists and palliative care, are important when having discussions with families about neuroprognostication. But the take-home message is wait, and wait at least 72 hours, if not longer, for patients when there is especially no clear objective evidence of catastrophic injury in patients who remain comatose. So how do we work through these? 2/3 of our out-of-hospital cardiac deaths are due to neurologic complications, and even with survival, a significant number will have neurologic sequelae. But as I said, one needs to look at a constellation of prognosis, and often what we're looking for is to identify a couple very bad markers that could then make us confident to say that poor outcome is likely. And these can be things like no pupillary or corneal reflexes more than 72 hours after return of normothermia, bilaterally absent SSEPs, a highly malignant EEG, elevated neuron-specific enolase, which is a blood test at certain time points, being in status myoclonus, or diffuse and extensive anoxic brain injury on CT or MRI. And if you have two of these, then there's a really, really high likelihood of very poor neurologic outcome. This is another recent algorithm from the Neurocritical Care Society, where again they recommend 72 hours of waiting after somebody has gotten to normothermia, avoid sedation and other confounders, use of multimodal assessments, and extended periods of awakening in patients with indeterminate prognosis if it's consistent with goals. And so these are the patients who often do end up requiring a tracheostomy and a feeding tube to be able to go to a skilled nursing or skilled acute care, post-acute care center for weeks of observation to understand how their neurologic recovery will occur. Now, the good news, is we are seeing improved cardiac outcomes after cardiac arrest. And if we look in the 90s, survival was, 1 in 100 and 1 in 10. If we look in the early 2000s, 1 in 5 patients, even with VT or VF, were surviving. And in the more recent studies from the TTM2 trial in particular, 60% of patients who are admitted with a shockable rhythm are surviving out of the hospital. In patients with non-shockable rhythm, it's much lower. In patients with a PEA arrest, it tends to be down closer to 20% survival. And if somebody has asystole as their initial rhythm, it's still less than 5% survival. Or also, it's interesting that of survivors, this was I think an optimistic or hope-filled report that looked at 685 survivors of cardiac arrest and looked at them a year later, and only 4% of patients were in supported accommodations, meaning they needed help with their ADLs or were still intubated with a tracheostomy. And almost 3/4 of patients had returned to work, most at their same role. So if somebody does get out of the ICU and out of the hospital, they can do quite well. It's not an easy road, and there are clearly traumatic brain injury, anoxic brain injury symptoms that are slow to recover and may benefit from pretty intense rehabilitation, but people can get a meaningful quality of life if they are on the road to recovery at the time of discharge from the hospital. So in conclusion, post-cardiac arrest care requires multidisciplinary critical care, including neurology, cardiology, intensive care medicine, and palliative care medicine. Identify and treat the causes of arrest early. That is job number one. And then every patient who is non-responsive after a cardiac arrest should have a plan for controlling temperature. And for most patients, this will be enforced normothermia, as I mentioned. There should be close monitoring of respiratory, hemodynamic, and metabolic and infectious systems, but nothing different for cardiac arrest patients than we would do in any of our other critically ill patients. And neuroprognostication remains challenging, as I mentioned, but it benefits from multiple modalities and requires patience. So here are some references of the most recent guidelines, as well as some of the most recent studies. And as I mentioned, keep an eye out for updates to the American Heart Association ACLS guidelines that should come out at the end of 2023. Thank you very much.